Live now, Kevin.
Good morning and welcome to this meeting of the Board of Directors of Lincolnshire Partnership NHS Foundation Trust. My name's Kevin Lockyer and I'm the Trust Chair. It's our normal practice to start our board meetings with a patient story. Unfortunately, that patient story is slightly delayed this morning, so we will come to that in a minute. So we're going to do some of our normal routine business while our external contributors to that patient story are sorting out their ability to be able to join us. So we will start then with apologies for absence. I don't think we've got any.
Apologies, Kevin.
Yeah, thank you. Declarations of interest, they are as recorded with additions for our two new executive directors who are joining this board of directors meeting for the first time. So I'll say welcome to Dr. Girish Kunagiri, our medical director, and to Amy Beaton, our director of people. So good morning. Oops, I see in chat that Di, you have a comment.
Morning, Kevin. Di Bailey, non-exec director. Just to confirm that I've ceased being the Pro Vice Chancellor for Research and Innovation at Nottingham Trent University, so we just need to amend my declarations of interest, please.
Thank you, Di. And sorry for not spotting your comment. I was getting ahead of steam up there and didn't spot it. Let's then go to the minutes of the last Board of Directors meeting on the 29th of September. Does anybody have any comments or points of accuracy on those minutes? No? Does anybody have any matters arising? If not, are colleagues happy for me to sign them as an accurate record? Fab, thank you. I shall do that then. We'll move on to thank you very much. So we'll move on then to the schedule of actions. They are as described in the paper, which I think pretty much speaks for itself, but happy to take any questions or comments. If there are none, then we'll move on then to the next item, which is remarks from the chair. Now, in previous meetings, I've provided a written note. I haven't done this time because there's a relatively short gap since our last meeting, and I don't really want to write papers for the board for the sake of writing papers for the board. The only things I would reflect on are that we had what I thought was a really excellent board development session a couple of weeks ago, and we are, I think, making really substantive progress in developing an ambition for the board, for the trust rather, to inform our strategy in the future and to articulate our place in an integrated care system. I'm really pleased with the way that work's going, and I'm really grateful to board colleagues for contributing in that. We've got another board development session on the 15th of December, where we'll be joined by the chair and chief executive of the Integrated Care Board. So I think that gives us a really good opportunity to parade our wares, as it were, and to start to position the Integrated Care Board around, what we see as our unique contribution to the system, and more importantly, to discuss with them the sorts of freedoms, for want of a better word, we might aspire to have to make the best of the public investment in mental health, learning disability and autism services. So that's that. I attended a meeting of the Integrated Care Partnership yesterday, at which we discussed the shaping of a integrated care partnership, and that's the wider kind of universe of district, local authorities, and other stakeholders. That was a useful meeting, I think, and I think the trick is for the ICP is going to be to focus on those high-level issues that impact on health and well-being, but which can't be tackled by individual organisations. So we reflected on some of the kind of social and economic determinants of health and well-being. So it was a useful session. Our patient story contributor has now just arrived, so I will, and in a very timely way, because I didn't really want to add anything more to my comments. So bear with me for a second while I pull myself together. Good morning. Can you hear us all right?
Hello?
Hello, is that Alison?
It is, sorry, yes.
Yeah. Morning, Alison. Really nice to meet you. My name's Kevin Lockyer. I'm the Trust Chair.
Hi.
Alison's joining us this morning, and forgive me if I give a kind of running commentary of what you're doing, because this is obviously a public meeting, so I need to introduce you. So Alison's joining us to share your story about your son, Jack. Unfortunately, we haven't been able to make the technology work for us to be able to see you, but we can hear you. Yep. We're also joined by Eve Baird from the Trust, who's hopefully here to provide some context and to help you talk through your experiences, Alice, or more importantly, your son's experience. So I'll shut up now and hand over to you. So the floor's yours.
Okay, so I would like to give you a little bit of context. So my son Jack is 18. Jack has quite a lot of issues. He has autism quite severely, and he's non-verbal. Jack has ADHD as well. He also has epilepsy, and with all these various things, Jack has quite complex behaviours. When he was young, we used to describe him as a cross between an Andrex puppy and an orangutan, because Jack is into everything. He gives the impression of not particularly listening or understanding, but over the years we've realised that actually Jack does understand quite a lot. He gets very frustrated when he's trying to communicate and people don't understand. Jack currently goes to Kismall, which is a special independent school based in Swinderby for children with complex behaviours and autism and ADHD, etc. Jack was born in 2004. And in the beginning, it was relatively easy to get support for Jack because he had an obvious delayed development. Sorry, I just need to mute something. That's better. He had obvious delayed development. But although we were able to get Jack into the system fairly easily, we then had lots and lots of fights. Unfortunately, we found there is no particular service for complex children such as Jack, or adults either, in Lincolnshire, and there have been very few opportunities. So Jack has, and us as a family, have found ourselves isolated, unfortunately, because while he was younger, it was easier to manage him. As he's got bigger, I mean, he's a full-size teenager now. He's a big, strong, and often quite loud lad, but still, obviously, with the mind of a younger child. One of the biggest issues we have with Jack is that he really wants to play in things like play areas and soft play because his interests haven't changed, but now he's become an adult. It's become very, very difficult to access anything like that. So that's sort of Jack in a nutshell. We've been to tribunals and things to access education, but one of the challenges that we have found with accessing healthcare is that as a child there was no support, and we found it was very dependent on the individuals that we met what sort of service Jack had. Now, we were very fortunate that almost by accident we ended up at Great Ormond Street, because Jack has an eating disorder in that Jack doesn't eat solids at all. Another thing that's been quite a challenge to sort out. But as I say, it's been very dependent on the individuals that we have met. And fortunately, my background is NHS, which means that I've known who to talk to and how to talk to them about certain things. But generally, there's been an overarching sort of impression that you are just Jack's mum, and we tend to be sort of ignored slightly. And because Jack doesn't give any feedback to anybody, often Jack gets ignored as well. It's very difficult to explain that without you seeing that. So Jack had a bad accident back in 2016, as I was explaining to Eve, where he fell from a height that he shouldn't have been able to get to, but that's another story. And Jack had to come into Lincoln Hospital, into A&E, because Jack doesn't necessarily behave like other children when he was in pain, etc., etc. He was getting ignored in A&E, and we ended up sitting for something like 6 hours with what turned out to be a horrific fracture for Jack. And you know, things really could have gone quite badly wrong. He then had to have an operation, and unfortunately during the operation picked up an infection in his arm, which again wasn't picked up despite us being very concerned. We were discharged home, and despite us being very concerned by the change in Jack's behaviour, our concerns weren't being picked up by the staff because they didn't recognise what was going on as normal signs of illness, if you like. In fact, the whole thing turned into a horrible nightmare, and we had no advocate. So, sorry, this is incredibly difficult to do when you're on a telephone and you can't see anybody at the other end. It's incredibly difficult.
I understand that, Alison. Would it help? Would it help you if we were to pause there and, you know, maybe ask you some questions so that we have more of a conversation and it feels a bit less like a monologue?
Yes, thank you, because yes, that would be marvellous. Okay,
and forgive me, I have called you Alison, and I didn't ask your permission. Are you okay with that, or would you prefer?
Yes, absolutely. No, Alison's fine. As I explained to Eve, the only thing I really don't like is Jack's mum, as I've just said to you, because it just it reduces. It's one of the things that's most common in healthcare, unfortunately, is that they often. I've done it myself. It's because you are trying to remember different names, and as a healthcare worker, you only have the name of the child or the young person. You don't have the name of the parents, and it's difficult to remember another name. But it also does just devalue your position, if you like, in supporting your child or young person. So yes, Alison is fine, and please, yes.
Thank you. I didn't mean to be presumptuous.
No.
I've got a comment I'd like to make. I've got a couple of colleagues here that do too. I'm going to start it though with Eve, because you're, you know, kind of closest to Alison and Jack, and you might have some comments to add.
Thank you. Yes, I just wanted to give a little bit of context about how I came into contact with Alison, because she sent an email to PALS around a really positive experience she'd had with our adult learning disability liaison service with Jack, and that's the service that supports adults with learning disability or autism to access appropriate physical health care in primary or secondary services. The reason I followed that up with Alison was within her email there was references to previous experiences that had been a lot less positive, and so what I've asked Alison to share in this time today is a bit of all of that, the good and the challenges, because what spending time talking to Alison did for me was inspired me to think about what we might want to do differently in LPFT, but equally what, as the lead provider for learning disability and autism, we want to be advocating for across the system. So some of what Alison shared with me made me stop and think a way I hadn't before. So I just wanted to give that little bit of context of how we met and why I felt her story was so important.
But thank you, Eve. That's really helpful. I mean, I'd say one thing, Alison, and that is that as a trust, and I think as the NHS generally, and you've alluded to this, we don't listen to families enough, and we don't take as broad a view of patients in the kind of circumstances that you've described as we might, but that's an admission that we can do better, and I know we can, but I hope we are also, in our kind of transparency, clear about the fact that we want to do better, and I hope having you here this morning and listening to you is a kind of concrete demonstration of our hope that we can do better around that in the future.
Yeah, and one of the things you've just said is really, thank you, giving me some structure. So one of the issues when you are involved with a young person such as Jack, whether you're a parent, a carer, or whatever, when you're representing Jack, unfortunately, the onus to access support is always put onto that person. So I'm going to talk as a parent because I'm a parent and this is my experience. So in the past, things like patient passports have been just fill this in, and it's been fill out paperwork. I cannot tell you, one of the reasons that I'm struggling at the moment is because the amount of just fill out this paperwork, just do this survey, just complete this. Oh, and we need it back by next week. If you could, the sheer volume of stuff to do proactively as a parent is overwhelming. I mean, I've recently gone back to work in the NHS, just for some sanity, frankly, just to sort of remind myself who I am. But the amazing thing about Judith and Lorraine was that they came to us, they asked the questions, they produced the document, they worked out what was important, they took away the information, they collaborated with the people that Jack was seeing. So they took an enormous amount of pressure off. So yes, I've been sent patient passports before. What does Jack like? What does Jack not like? What does Jack do? And as helpful as they are, and as great as that is, and I can really see that trusts across the country, because I've seen it in several trusts, are trying really hard to get that information out there. It puts an awful lot of onus on the parents in this case to produce that information, and it's unbelievably overwhelming. So Judith and Lorraine, because they are working with us and continue to work with us, as you say, through primary and secondary, Jack accesses something like, I've just done a quick calculation in my head, he's accessing something like 5 different trusts at the moment for different things. So that information goes to the different trusts, and we don't have to start again each time because they've done all that work, and that has been invaluable, absolutely invaluable, to take some of the pressure off us as parents. So that's one of the brilliant things. Sorry, back to you again.
Thanks, Alison. That's really helpful. And I think this notion that parents are, as it were, passive providers of information, and we can't work with you to understand things better and take some of that burden off you is a really important point. I've got a comment from a colleague, Sharon.
Yes, thank you. Morning, Alison. I'm Sharon Robson. I'm a non-executive director. I just wanted to pick up on your point about advocacy or care coordination, and just in terms of that, was there ever a point at which all of the services involved ever got together? Was there any attempt to coordinate that care on your behalf?
So when Jack was first diagnosed, we were introduced to something by a healthcare visitor way back in the beginning that was called Team Around the Child, and that was a point where we were supposed to get input there from education, healthcare, yada yada, all the various different people coming into Jack. But the reality is that often it would just be a healthcare worker and a letter from a consultant, and someone from nursery would rock up and everybody else would send apologies. So unfortunately, it didn't work. Now, interestingly, since COVID, and Jack is obviously a lot older now, things are a little bit better because we've accepted the idea of Teams. I mean, obviously you're doing this on Teams. So Teams has improved things slightly because people can spare half an hour from their office, whereas it became very difficult for people to cross from Lincoln to Grantham, come from Sleaford. And so things have improved now. But no, even though there is this coordinated service theoretically, it really doesn't happen. I mean, Jack has an annual review every year, and half the time we get apologies from people. One of the best people that has managed to coordinate and take pressure off us as a service has been Jack's social worker. If I can talk about Jack's social worker pre-turning 18, but getting a social worker, even though Jack is incredibly challenging. So I first approached social care when Jack was about 5 or 6. I was just buckling under the weight. So please stop me if this isn't appropriate. But you get a diagnosis or you don't get a diagnosis. Either way, you find out that there is something about your child that is very different from the child that you thought you were having. Now, for Jack, it became obvious quite quickly, although I had to fight and camp out in various A&E departments and make a fuss. I was aware that there was something different about Jack. So Jack was about 1 when we eventually found out that he had a genetic disorder, which I completely forgot to mention to you. So Jack has a genetic abnormality. Unfortunately, there is no other abnormality on record, same as Jack. So it doesn't really mean anything except that there is something genetic going on. And we got a diagnosis to say, look, Jack has delayed development, and there is this genetic abnormality, and we're not sure what this means, but anyway, thanks and goodbye. You don't get any sort of counselling, you don't get any sort of support, you don't get anybody that works with you to help you understand the consequences of what they've told you. And the other thing they don't warn you about, which came as a complete shock to me, is that most parents go into a grief cycle. It sounds ridiculous because nobody's died, but in actual fact, when you have a child, anybody that's listening to this who has children, as a woman, you're imagining in your head your trips out with your child, things that you might do. Christmas was a big one for me, the Christmas traditions that I could introduce to Jack, the places we would go, the positive things that I would take from the relationship I had with my parents and do with him, and the relationship he would have with grandparents. I daydreamed about all of this, going to university, whatever it was. This is what my son was going to be. For my husband, who's a keen rugby enthusiast and played for many years, ex-military, Jack was going to follow on in his footsteps. He couldn't wait to start coaching. He'd already started looking up about tag rugby almost from the day he was born, how we could get him into rugby. first thing he bought him was his little England rugby outfit as a baby. First big disagreement we had was the fact that I'm Welsh and I didn't want him to play for England. And we actually had a disagreement about which country our son would play for, because that was the sort of thing that parents think about. So complete shock. We're told one day, this is the situation. Your son's got learning disabilities. We don't know what this will mean. We were told he would probably never talk and he would probably never walk. And it just comes as a terrible shock. And you're sent away. Carl wasn't affected by it quite as badly as me, because he's an eternal optimist, and he was going to do this and he was going to do that, and he'd known people who'd been diagnosed with this and they'd managed to do that, and we were going to push forward. But I was going to baby and toddler groups and mums and things, and I was gradually noticing more and more things that Jack couldn't do. And this is where a lot of families literally fall apart. Families split up in this situation, and there just isn't any support there at all for people who are finding out that their child is going to be very different. Generally, if there is any support out there, it's aimed at what I would call mainstream disabilities. I'm not taking away anything from anybody that has a child with Down syndrome, but Down syndrome is the sort of condition that is recognised. I'll be honest, it was the only sort of condition I really thought about when I was pregnant. You know, do you want the test to see whether your child has Down syndrome? Oh yes, we'll do that because it'll mean we're prepared. You know, I hadn't really thought about anything else. But if there's one thing I really, really wish I could change, it would be the support for parents when they first get a diagnosis. And then to go back to my other point that I've wandered off from, social care, I got myself in such a muddle. I was very, very depressed. I was still managing to go to work part-time, and I was hiding it from everybody. And because I couldn't understand why I wasn't coping when I saw everybody else was managing brilliantly. And eventually I went begging to social care, because I'd been told you can have, I was told by the community paediatrician, you know, you can access social care, you might be able to get some support, you might be able to get respite, because I really, really wasn't coping. Jack didn't sleep at all for the first, 4 or 5 years. I'd go to work on 2 hours sleep if I was lucky. It was incredibly difficult. And I went to social care. I was told you can self-refer, you ring the help desk, and you will get an assessment. And I rang up and got a social worker to come out and do an assessment. And I was turned down from social care. I was told that I was too well educated to need social care. I was too eloquent. I had a job, therefore I was getting respite, and they couldn't help me. And I did one of these team around the child meetings, and I was told there to write a statement about how having Jack has affected family life. So I did. I sat down and I wrote a two sides of A4 as a statement. And yes, I am fairly eloquent when my brain's working. So I wrote this, and at the end of it, the woman that was there to basically decide whether we would need more support as a family said, well, it's all very me, isn't it, Mrs. Telfer? And we're not really here for you. We're here for Jack. And Jack seems to be doing okay. And I was sort of rejected from any support. So the only reason I got a social worker is because I went to one of the Lincolnshire parent carer meetings, and the head of social care for children was speaking at the meeting at the time, and she was there reassuring us, you'd heard there are going to be lots of cuts, you've heard that there are going to be problems, and you've been told that getting a social worker was difficult. I'm here to tell you differently. This is what's available, blah, blah, blah. And I waited to the end and any questions from the floor, and I screwed up all my courage, and I thought this is probably I felt like I was doing something very silly, but I thought, sod it, I'm desperate. And I stood up and said, basically, why is it in Lincolnshire you only seem to help when it's too late? And I told them that I'd had an assessment and what I'd been told. And she asked me to talk to her at the end. And I said, no, I want to talk to you in front of these. I think there were 500 people there. And there was also a couple of journalists because it was an annual meeting. I want to talk to you in front of all of these people because I know I'm not the only one. And I brought up several cases of parents with children with disabilities and adults, actually, where parents had gone on to actually kill themselves and harm their children. Children had died as well. And there'd been inquiries. And in the inquiry, whenever there's an inquiry in Lincolnshire, the response is always, well, lessons will be learned. But I felt that lessons weren't learned because things had always gone too far for them to help it. I mean, I was at breaking point at that point. And I then became a high-profile case, apparently, according to somebody who worked in social care who told me afterwards. And I got a social worker, and things started to get better. But there are lots. I should have said I'm also a trustee for Grantham Disabled Children's Society, obviously a group based in the Grantham area, and I've been doing that for a lot of years. And I meet loads and loads of parents who are in the situation where I was, where they are desperate. And I have told them what they need to do to get through. And so many of them have come back to me and said, I just couldn't fight anymore. I've had to give up because I was too exhausted. And there are so many people who aren't even getting the support that we got. But sorry, I've gone off on a tangent again.
No, you haven't at all, Alison. And what you're telling us is a really powerful story that in lots of ways is difficult to hear because it is critical, and rightly so. I think that part of our role is as a trust is to advocate in the wider health and care system for people like you and Jack, and the kind of wider care and support that you need. But I've got another colleague who'd like to ask a question. Then I'm unfortunately going to draw things to a conclusion, Alison, because unfortunately we've got a busy agenda of other things to talk about. But I'll bring in Chris Higgins now.
Thank you, Kevin. Morning, Alison. Yeah, Chris Higgins, Director of Operations. Really interesting to hear your story, and very thought-provoking. I think one of the things is we're doing as an organisation is trying to understand how we can better help the experience of people with mental health, learning disabilities and autism problems across the whole system, not just the part that we deliver as LPFT. And I'm just curious as to how we did with that for you and your family in terms of were the actions that we did as an organisation helpful, or are there other things that we might be able to do to make your experiences more positive in other parts of the system as well as our own?
So when we were referred to the liaison service, it was such a breath of fresh air. We actually felt listened to. It was obvious that Jack was a priority. Once Jack had turned 18, we were very anxious because there are all sorts of horror stories, and they're not just fables that have Chinese whispers that have been passed on, but things that have happened to genuine people and friends where parents had not been listened to. And Jack was going for dental surgery, and I was particularly anxious about dental surgery because there'd been situations where someone I know had gone, their child or their young person had gone for dental surgery, and the dentist, it's a few years ago, had decided, you know what, it'd just be easier to whip these teeth out. Take them out now, that'll solve the problem. And the young person had come out of theatre without their teeth. And the parents were absolutely horrified because they hadn't been consulted. But there's no need to consult the parents because the parents are no longer, you don't have parental responsibility once that child has passed 18. And the surgeon had deemed it in the best interest of the child. We had an issue when Jack was 4 years old where Jack was going deaf. It turned out he had glue ear and we needed Jack to have grommets. And we were told, well, you're a low priority because, well, he's got learning disabilities. It's not really going to make that much difference to Jack. So they made him a low priority. This was in Lincolnshire. At the time, I still had a lot of fight left in me and I was horrified. So my husband and I kicked off. It was one of our first complaints. And we were listened to eventually because we were parents. So this fear of things being out of our control, and Judith and Lorraine did a great job of reassuring us and therefore lowering our anxiety. They already told us that they'd worked with the surgeon before, they'd worked with the team before, they were very geared up. The dental Max Fax department would then, they got the consultant to actually ring us at home and have a chat, and he allayed a lot of fears, etc., etc. And what the brilliant thing about this was that it lowered our anxiety, which immediately lowered Jack's anxiety. And I can't ask Jack about his experience of going into the hospital for dental surgery because Jack doesn't give feedback like that. But Jack treated it like any other adventure. As far as he's concerned, there was no negative feeling from that experience at all. It was seamless. It was brilliant, and that was just the most positive thing, which is why I wrote the positive comments to PALS, as I say, because in the past it's all been negative. So one of the concerns I have though with the service is there is still a lot of work where they will be working with different teams. So one of the problems we've had in the past, the biggest problem has been trauma and orthopedics, where there's not necessarily been planned admissions. And that's where I'd like to make sure that there is, when it's not planned, that the liaison service are listened to. That's where we've had, as I say, we've had our problems in the past. So I think that's where a lot of the work needs to be, where there isn't a planned admission into hospital. It would be nice if there was someone you could ring who would come and support at those times, because that's often where the most anxiety is for people with mental health and learning disabilities. And the other thing that I would really ask is, why is the service, which is, like I say, brilliant, why is it not available to under 18s? I could tell you a number of horror stories from other people that I know where their children have been left permanently traumatized and unable to go inside a hospital building because of things that have happened to them, where there has not been this liaison service, and it could have been very different. One parent in particular had an experience at Boston, which I won't talk too much about because I believe there is litigation happening, so it would be inappropriate to talk too much about it. But she is a very sensible parent. She knows her child very well. She works in special needs social care, so she knew about she knows who to talk to and what to talk about. But in actual fact, her requests for reasonable adjustments were totally and utterly ignored because the surgeon didn't understand the reasons for her requests and disregarded them. And it ended up, as I say, with a situation now where the child can't even walk in the doors of the hospital without being totally overwhelmed, to the point where yesterday he had an accident, fell and cut his knee, and the knee needed stitching. And someone had to come from the hospital and do a home visit, which for the child was great. But from the point of view of NHS management, you know, it's a huge resource that's being taken away from the hospital at a difficult time. And all this could have been so easily avoided with something like the Disability Liaison Service being rolled out to under 18s. I don't want to sort of keep banging on about it, but yes,
No,
the service that you have is brilliant.
You're not banging on at all, Alison. And Chris, thank you for your question. I mean, I do think that as a trust, we see one of our roles as ensuring that, not only do we advocate effectively for Jack and other patients and carers, but that we do so in a way that actually mobilises a response from other organisations in the health and care system. Look, Alison, thank you very much for I'm really conscious that we've had you on the phone for as long as we have, and I'm sure you have other things to go and do as well. But you've given us an awful lot to think about and to reflect on. And so I want to thank you, Alison, not just for your time, but for the openness and frankness that you've displayed this morning. And I'm perfectly aware that kind of recounting all of this thing isn't necessarily easy, and certainly to do it when you can't see us is even harder. So thank you very much for that.
Yeah, one very final quick comment is I'm conscious that I don't feel that I've managed to be as eloquent as I would like to have been and as helpful as I'd like to have been. But if anybody would like to email me, obviously Eve and Amy have my email address, and if anybody would like to ask specific questions, if anyone would like to, if you'd like to use the groups that I belong to and grant them as a sort of research or sort of like a test pool or any questions, please do get in touch. I do work quite well on paper. Yes, I know it's giving myself more work, but if it makes things better in the future, then I'm all for it.
That's very kind of you, Alison. And the last thing I would suggest is that you lack eloquence.
Unfortunately, as Eve and Amy know, I've got COVID and I'm just coming out. I hope to test negative today, and it scrambles your brain.
Yeah, no, absolutely.
Apologies.
It certainly does. No, none necessary. Alison, thank you very much, and thank you, Eve, for joining us this morning as well.
Thank you.
Thank you very much.
Thanks, Alison.
Okay, bye-bye.
Bye. Should we move on to the rest of the agenda? I think we need to reflect on some of the things that Alison has raised this morning, but I think we need to find some protected time, as it were, to do a bit of that. And there's some things raised by that conversation that we might well want to reflect on in our next board development session, because it plays, I think, directly into the thinking that we've done around the future ambition for the trust. So we do need to move on to the rest of the agenda, and I think we were on item 2.1, Sarah, which is your report.
Thank you, Kevin. Good morning, everybody. My name's Sarah Connery. I'm the Chief Executive here at Lincolnshire Partnership NHS Foundation Trust. I am at risk of losing my voice, so I'll save some of my energy for questions, and will assume that the usual report that I present is read. Just to start off, in terms of COVID-19, we don't currently have any updated national guidance since my last report to the board, but the trust is having to manage an increasing number of live outbreaks in services. At the time of reporting, there were 9, so we're continuing to ask staff to be vigilant with regards to infection prevention and control measures to minimise the chances of infection. And as the weather's taken a bit of a turn, making sure that we keep rooms well ventilated does come with a challenge. But needless to say, we need to make sure that we're keeping ourselves and our patients safe, and encouraging our staff to uptake their boosters for COVID-19, as well as seasonal flu vaccinations as well. So doing a massive comms piece on making sure that people can access those vaccinations. Just from a national and regional point of view, I just want to bring the board's attention to the fact that the new NHS England operating framework, it's been much Trails was released on the 12th of October 2022 in response to making sure that we've got the structures in place to enact the Health and Care Act 2022. The document's quite accessible. It sort of splits the roles between NHS England, integrated care boards and providers. And for us, the key responsibilities, as we know, is to ensure that we're delivering safe and effective and efficient high quality services. But it's also our responsibility to make sure that we're contributing to effective system working and delivering of integrated care system strategies and plans. Needless to say, there may be tensions within those two responsibilities, which we will need to work through as we develop forward as an integrated care system. There will be more guidance to come. This was just a framework for more guidance in terms of throughout the rest of the year. In my report, I do make a reference to the Panorama programme, but we've got a separate report on that under 4.2 in terms of our initial trust response. So I won't say any more on that at this point. October 2022 was Freedom to Speak Up month. The theme being freedom to speak up for everyone. Really great engagement from our team, so thank you for that. And we heard a lot from our Freedom to Speak Up Guardian. As you know, the Trust shows a real commitment to speaking up. I take every instance of speaking up seriously, and 100% of LPFT colleagues who raised concerns and completed the feedback have said that they would speak up again, which is a percentage I'm particularly proud of. World Mental Health Day on the 10th of October, so a big thank you to those who attended, teaming up with Lincoln City Football Club as part of their home game against Charlton Athletic. So we spoke to some of the players to talk about what they do to improve mental well-being. It's really important that we engage with our local communities about speaking about mental health issues to reduce stigma, particularly for males as well, in terms of responding to the suicide statistics that we see across the county. NHS staff survey is live, so we're trying to encourage as many staff as possible to complete that. We had a really great uptake percentage of 64% of staff last year, and we're hoping to meet that or preferably exceed it to make sure that everyone has had their voice heard. More on that to come. In terms of Lincolnshire and LPFT, we're continuing to progress with our winter planning approach, not just as LPFT, but of course across the system and across the region as well. We had some dedicated time at our Lincolnshire Leaders Board on this last night. Some progression around having a system ops centre, which will come into force on the 1st of December, as well as building a single version of the truth in terms of our data dashboards as well, in terms of where we are. In terms of our staffing and keeping resilience across our services is our main risk. And under 4.5 we'll talk about a difficult decision that we're having to make around the temporary closure of our psychiatric intensive care unit in order to improve that resilience as we go forward into winter. I'll just end to talk about our workforce summit that's been trailed again previously. In terms of this is our biggest risk on our risk register. Delighted that Amy Beaton started this week as our substantive director of people. And the workforce summit was some protected time for us as senior leaders in the organisation to come together to have some real honest conversations about what are some of those barriers to moving forward with some of our innovations around recruitment and retention. We've got some clear actions and some governance around that in terms of coming through the people board and up to the board, sorry, the people committee and up to the board. But I think the actual framework and the approach was very well received, and we've agreed that we'll have quarterly sessions picking up throughout 2023 with dedicated focus on each of those key themes identified. Finally, celebrating success, we had our Values Awards on Thursday the 6th of October, and in the report there is a bit of a YouTube video that people can watch if they weren't able to attend. It was Quite an emotional evening, but absolutely vital with all of the sort of bleakness that's out there at the minute to take some time to celebrate all of the fantastic work that's going on at the Trust. And a massive thank you again to our very dedicated comms team who will run ragged that night to make it such a success. So a massive thank you again. And I'll stop at that point, Kevin, because my voice is going.
Yeah, I
to take questions.
I can hear that, Sarah. You might want to reply to questions by semaphore or through the medium of mime or something. But questions for Sarah. Tim.
Hi, Tim Harry, non-exec director. Sarah, thanks as ever for a great report to read. Sort of quick question is really around that piece around the new NHS England operating framework, and we've had questions and concerns about how all these fit together with our sort of sovereignty and statutory sort of role. In the development of this sort of framework, is that sort of being addressed? You can
really
just
great
nod,
question.
you can just nod if you like.
Yeah, it is. I think specifically, it's always been a concern of mine really around the Foundation Trust model and what it means for governors and membership specifically in terms of the framework. And it is specifically referenced that there is no change to that.
Oh.
So I have been thinking about how we might want to have some time to kick it around, and I was going to pick up with Kevin in terms of maybe we sort of highlight some of those areas for a future joint board with our Council of Governors.
Thank you. And you sort of picked up my secondary question or inference. Was there going to be a change around the trust statutory? But you're saying no, it's going to stay.
No, but not that doesn't come with tensions in terms of navigating it, I suppose.
Yeah.
is the key point there. Thank you.
Thank you.
Thanks, Tim. Ian.
Thanks, and just to echo what Tim said, a really helpful report, Sarah. The one thing I just wanted to touch on really was the point you made about winter pressures and all the planning there that I know is always very intensive. Just wanted to say a little bit more about the position in Lincolnshire, because you hear nationally that this might be more difficult than it's ever been in the past and so on, and we know we've got the autumn statement coming along. I just wondered whether you've got any further insight how much more difficult it might be.
Yeah, it's a really good question, Ian. I think the approach that we were taking, that we talked about at Lincolnshire Leaders Group, is that scenario planning in terms of how bad could it be and what would our response be to that. And I think COVID, some positives, as we'd like to sort of see the positive in anything, has helped us in real time enact some of that business continuity approach, and indeed in terms of industrial relation risks as well. If we do see a surge in flu and COVID and we have industrial relation actual strikes going on, if the ballots swing that way, what does that look like in terms of a scenario? But I think the key point is really good quality data, single version of the truth in terms of that data dashboard as a system, and that includes mental health information in crisis as much as it does about ambulance delays and handovers, because it is connected, and having that system control, that system ops center, I think, as for oversight, so that it's real time responses as a system, which I think is one of the benefits of having the integrated care system, so that we're working more together collectively rather than trying to deal with our own issues individually. I think it's one of those where it's got to be right for Lincolnshire, because the single ops centre has been a model that's been trialled in some areas of London, for example, where you've got multiple acute trusts, multiple mental health trusts, so we are a little bit more simple than that. So yeah, I think it can. I think what we have to do is have good quality data, single version of the truth, and really good scenario planning in terms of you know, worst case scenario and what that might look like. I hope that's helpful.
Yeah, it is. Thanks, thanks, Sarah. I knew when I asked it, it's a very, very difficult question because you know, we don't know exactly what the scenario will be. But yeah, thank you for your comments.
Thank you.
Thank you, Ian. Sarah, I think there's a more general point around that, and that is that I'm not seeking an immediate answer to, but we probably need to think about separately is how if the situation, I'll try and get my words out in an order that makes some sort of sense. If the situation does deteriorate over the winter because of all of the factors involved in that, how we kind of escalate our management of that up to the board. So, you know, when we know we're going from a normal business as usual way of doing things to something that is, you know, kind of a lot more, that looks a lot more like and I hesitate to use the term, but you'll know what I mean, a kind of emergency response, and you know, how we what the steps in that escalation process look like. Yeah. And that's something I think that we probably ought to spend a bit of time around the board table, as it were, thinking about. Chris.
I'm going to camera on. Yeah, Chris Higgins, Director of Operations. Just to say that obviously with everything that's going off at the moment in terms of industrial action and winter pressing and things, we've used the opportunity to refresh our major incident plan for the organisation, and that's just in the process of refresh at the minute and going to Health and Safety Committee on Monday next week. And within there, I'll just pick up with our emergency planning officer that point around being clear within that about those routes of escalation to make sure it's clarified as part of that process.
That's really helpful, Chris. Thank you. I don't see any more questions or comments. So, Sarah, thank you very much. Give your voice a rest for a few minutes.
Thank you.
And we'll move on to the risk register. Jenna.
Yeah, good morning, everybody. I'm Jenna Davis, and I'm the Director of Corporate Governance at LPFT. So outlined in the paper is the organisational risk register, which includes all organisational risks that are rated 15 or above, which there's currently 10 on our risk register, and those risks that score over 12 but require an organisational response, and there's currently 8 of those. I didn't want to pick up too much on the report because I think it's self-explanatory, but I just wanted to highlight the areas around the improvement. And so over the coming months, I'll be working with colleagues across the trust, including board colleagues, on reviewing the risk management strategy and approach in the organisation, and especially picking up the alignment between the organisational risk register and the BAF.
Thanks, Jenna. Sharon.
Thank you, Chair. Jenna, you may not be aware, but in Lincolnshire we have the Lincolnshire local, excuse me, I've got COVID, as you know, the Lincolnshire local transformational plan for children and young people's emotional well-being and mental health. And this was refreshed last year. Now, on the register, there are 4 risks and issues that relate to the pathway of care for children and young people's mental health and well-being. And I was wondering, well, I feel that in order to provide a better assurance, that strategy needs to be embedded in our controls within those risks, because that's what we agreed to do. It's our priorities and the agreed governance arrangements for the delivery of that pathway of care.
Yeah, I can pick that up with Anita and Chris to make sure it's reflected moving forward.
Thank you.
Thanks, Sharon. Tim.
Thanks, Kevin. So Tim Harry, Non-Exec Director. Jenna, thanks obviously for the risk register. There's obviously some good movement in some of the risks in there, you know, in terms of some of the training rates, etc. I've got one question and maybe a comment. In risk 196, it talks about 8 qualified staff shortage, and it may be Chris Higgins who can answer this. I don't get a sense of what the relative numbers are. What is it 8 out of in terms of numbers of qualified staff? The other one was a more general thing. You mentioned about you obviously doing some very active work on reviewing some of these risks, etc., etc. I assume some of the latter ones in the risk register are the ones that some of the ones that are being sort of picked up because there's not an update when there's been a review, for instance, at the end of September. So I assume they're all coming presumably at the next report.
I'll pick up the last point, Tim, and yes, they will be. They are new ones and they will be reflected in the report moving forward for the next cycle.
Thank you.
Hi, Tim. Yeah, Chris Higgins. Just, I think so. In question to the number you were referring to there.
So it's 196, and it was the early intervention psychosis team, and the risk is around if we don't fill a number of the vacancies, the high level of vacancies there. I was just trying to get a sense of what that 8 number of qualified staff shortage, what I mean, we can pick it up outside, Chris, if you like.
Fine. I mean, at the moment, we see there should be 12 staff in that post, and there's only 2, so there's obviously a number of vacancies there. But what we're trying to do to supplement then, just to give some further assurances, I've been working with the team about how do we best configure a county-wide offer whilst we've got a depleted workforce, and we're working with the other wider community teams to do some cross-team cover to make sure that we've got that supplemented while we recruit. And there's a number of other initiatives we're doing in terms of the service model to kind of correct and right-size the service model to reduce pressure on the team. But significant number of vacancies. It's one of our probably more fragile services at the moment that we're keeping a close eye on.
Yeah, thanks, Chris.
Thanks, Chris. Thanks, Tim. Chris Wright.
Thanks, Kevin. Excuse me, Chris Wright, Non-Executive Director. I was just wondering if Mark could give us an update on risk 205 and the fire dampers on the build at Lincoln Hospital.
Yep, happy to, Chris. So, morning everyone. I'm Mark Platson, the Director of Finance and Information. We've actually signed this off this week, Chris. So that will be coming off in the next report. So we have sourced an alternative for that. So the building's cracking on. So we're all good on that one.
Excellent. Thanks very much.
Thanks, Chris. Jenna, thank you for presenting the report. I'm pleased that you're going to be doing some further work on, kind of refining the presentation. I think that I agree with you that as a tool, we could do with refining how we reflect controls and mitigations. But I know that you're onto that, and look forward to seeing those changes carry through to future meetings. Should we move on then, if there are no further questions or comments, to item 4.1, which is a report from the Quality Committee. Di.
Thanks, Kevin. Morning, everyone. Di Bailey, Non-Exec Director. Just a few comments, I think, but I will take the detail of the paper as read. So at the committee, we received a lot of assurance in terms of the level of activity going on in relation to all of the quality priorities. In terms of some of the specific items that we considered, we started off with a deep dive around physical health checks, and this is an area where we're seeing an increase in the number of patients with healthcare needs that are in our services. And if colleagues look at the integrated performance report that we'll be looking at later, our target is to address those in 60% of our patient population, and at the moment we're tracking behind that. The discussion that we had at Quality Committee was about seeing that increase, but also about understanding that increase within the context of the wider system, because I think what we reflected on was that while we're doing everything that we can, and we're assured about the interventions that LPFT is delivering, what we felt we were less cited on was the interventions across the system, Kevin. So I think this is an area where we wanted to take that into a wider conversation with system partners about physical healthcare needs, And I think, hearing from Alison this morning how important it is that we have a joined up approach to that. In terms of the item around quality improvement initiatives, there are a number of these across the trust, and we were very keen to ensure that we are focusing these in areas where they're absolutely necessary, and giving staff the autonomy to make changes, simple changes where they can, that improve quality of care for people who use our services. So in terms of one of our priorities, which is around the reduction of restrictive interventions, this is absolutely an area where we are looking in detail at that quality improvement programme. And Anita makes reference to this actually in relation to the next paper in terms of how we're dealing with the response to the Panorama documentary. So a report around those larger scale, more complex quality improvement programmes will come back to each committee. There were a number of policy updates which we considered. The one probably most relevant is around the section 117 policy for people who are receiving aftercare. Of particular interest, I think, again, is because this is a policy that impacts across the system. And I think we were pleased to see that there was a much more structured approach in terms of the way that the amendments to the policy had been included, particularly to ensure that we're meeting the aftercare reviews at 72 hours, 6 weeks and 6 months, and then annually thereafter. So I think we took assurance from the detail there that that there is a coordinated and structured approach with system partners. I'll stop there and happy to take any further questions or comments.
I'm grateful. Thank you very much, Di. Sarah, I think you have a comment.
Thank you. Yeah, it was to do with physical health care checks for those with serious mental illness and learning disability. So I guess it's just for assurance really that it is discussed in terms of the whole system approach at the Integrated Care Board, and it was also referenced in the performance report at the Lincolnshire Leaders Group yesterday. And the Mental Health, Learning Disability and Autism Alliance kind of holds the ring in terms of the action plan. So I'll have a think about how we might link those two things up with Quality Committee, because, in fairness, I think what we don't do is represent it in terms of the bit that LPFT are sort of pushing forward versus the rest of the system. So it was just for assurance that it is looked at, but we can have a think about how we connect up those two bits of assurance. Thank you.
Thanks, Sarah. That's helpful. Anita.
It is a comment to Sarah, and it's a real plea, because we know in the past our performance data has looked positive around our physical health checks for SMI and learning disabilities. However, when we then look at the life expectancy and increased life expectancy, we've seen no shift in that. So it's a real plea that we don't focus on the numbers and actually look at the quality of those health checks as part of that work as well.
Thanks, Anita. Don't see any further questions, Di, so thank you very much for a comprehensive, really helpful report. Thank you. Before we move on to the next item, I'm going to suggest we take a short break. We've got a couple of really substantive items to discuss, and I think people might want to recharge their coffee cups and things like that. So it's currently 10:10. So let's have a 10-minute break and reconvene at 20 past. Thank you. Okay, thank you very much, everybody. Let's restart then with item 4.2. Anita.
Thank you. I'm Anita Lewin. I'm the Director of Nursing, Allied Health Professionals and Quality here at LPFT. So the paper I want to present now is our initial response to the Panorama documentary that went out on the 28th of September. As a trust board, it's important that we take the opportunity to look at the work that was and look at what was filmed that evening, and give ourselves the opportunity really to look at our systems and processes, to look at what we have in place, and to assure ourselves, as far as is feasibly possible, that what we saw that evening on that TV programme isn't happening within LPFT. There are a couple of bits that I'll pick up in part 2 of the board that I think it's important that are potentially commercially sensitive that I'll pick up later. But I think the key priority for me, once I'd seen this programme, there was obviously a lot of shock. There was a lot of, as well as the programme, there was a lot of additional coverage by the media, and our absolute priority was to reach out to the families and carers who have patients in our inpatient facilities who potentially would also have seen the programme and have additional worries about how their loved ones were being cared for within the organisation. So the immediate action was to reach out to the carers of all of our inpatients and just give them the opportunity really, if they'd got any concerns, if there was anything they wanted to share, if there was anything they wanted us to pick up. I am pleased to report but we did have several responses to that request, but none of them expressing areas of concern relating to LPFT. I reached out to the Safeguarding and Freedom to Speak Up team to say, and they kind of get together regularly and kind of triangulate information. One of the pieces that came out of that programme really was just appeared to be the lack of triangulation of concerns that had been raised previously in various forums. So we took the opportunity with it, and all of this happened literally within the first 4 or 5 days of the viewing of those. We know, we've heard from Amy Beaton, our new Director of People, in her Deputy Director role, that she'd completely revamped the employer relations processes, because as an executive team we weren't potentially assured that we were fully sighted on all of our employee relations. So we didn't know if, or we wouldn't have known if we had some areas of concern, but that entire piece of work has been revamped, and the new employee relation policies are kind of up to speed, and as an executive team we are now sighted on all of that information going on in the organisation. I think one of the key areas for me with this was our need to bring a level of independence to what we believe is good practice within LPFT. We have lots of evidence of staff speaking up when they think that care isn't as it should be. However, I just wanted us to stop and to think and to say, are we bringing enough independence into what we believe to be accurate? So as a result of this, we've reached out, and we do lots of work with our Health Watch colleagues and with Voiceability, who are our advocacy services. But we've reached out to them and asked them if they will become a regular feature of kind of coffee in a natter or coffee in a chat, or whatever we want to call that they're going to be a regular kind of presence on our inpatient facilities, so the patients have the opportunity. And it is really just to ask how things are. Do they feel safe in our services? Are they happy with that level of care, what they're getting? And just so we have a really robust kind of diary that's happened now, and are going forward well into 2023. That they become a regular feature really of our inpatient services. We know the quality leads who are based in all of our inpatient areas regularly ask our patients, you know, do you feel safe in our services? How does it feel to be on the receiving end of us? But as I say, it's important to bring a level of independence to that. I don't want anyone to feel that they don't have the freedom to speak up because they don't want that to affect their care. I've also, the patient experience team are also going to do random post-discharge checks with people as well, to ask how their care was in our services, the good bits and the not so good bits. We need the opportunity to be able to kind of learn and reflect on that. You heard from Di Bailey earlier around our focus around restrictive practice, the use of seclusion. We have very robust monitoring of our seclusion policies within LPFT. It's something I brought in many years ago. Placing somebody in seclusion is not something we should do lightly, and the monitoring and the robust checks around that need to be in place. So we've looked at that and we're reviewing that. We're doing a really revamping the restrictive intervention work and our quality improvement programme around our restrictive practices and our use of restraint. I had a very detailed meeting about that yesterday, and I think it's important that we really start to unpick our use of restraint, where it's related to people kind of displaying a violent incident, or where it's used with people where we're trying to prevent them hurting themselves. So they're very different kind of work streams. So we're unpicking that and working that through. In relation to this paper, I think it's fair to say there were some immediate actions that we took. There are some that we've taken and that we've identified that it's going to be an ongoing piece of work. This isn't, I don't want this to be a piece of work that is done in relation and in response to this programme and it ends up being a 5-10 day piece of work. I'm very clear that it won't be. I'm working with Jenna Davis, the Director of Governance, to really look at our assurance processes. Quality Committee had a really healthy debate on what does good assurance look like, and it's not about reporting activity. Activity is okay, and it's important that we have an overview of that activity, but actually what is the so what out of the activity that we're doing. So that's a piece of work that we're following through. And just one final part on this paper, and I'm sure there'll be comments and questions, is we also cannot take our eyes off the fact that not all Lincolnshire patients are cared for in LPFT services. So the piece, so this is our response as an organisation. It's been shared with the System Safeguarding Board and with ICB colleagues, but I've also thrown the challenge down to ICB colleagues to say, we need to see what you're doing too in relation to LPFT or Lincolnshire patients that are not being cared for in an LPFT bed. So there's more work to do there in the level of assurance that are provided by those. But this paper really concentrates on LPFT patients and patients that are in our beds and our services. So as I say, some highlights of work that were done immediately. Pieces of work that have kind of fallen out of that will be ongoing, that will report through to Quality Committee, and a full review of our governance processes just to make sure that we are as assured as we can be. And this is my second last final comment. It is a plea really to the people on this call, so the executives and the non-executive directors. We receive assurance, but we are responsible to go out and get some of our own. So when we are doing our non-executive and executive visits, to ask to kind of meet patients as part of those too, and to gain our own assurance. Let's ask how it does feel to be on the receiving end of us. Let's use everything at our fingertips really, and not rely on being given assurance. Let's go and find our own.
Thanks, Anita. That your final comment there, with which I agree absolutely wholeheartedly, segues into a comment that I was going to make before I invite comments and questions from colleagues. My view is that what you presented is really excellent and provides a good level of assurance to the board that we have the mechanisms in place to provide us with the assurance that we need. But Anita, you and I have had this conversation, offline, as it were. So you might be able to guess what I'm going to say. One of the fundamental failings uncovered in the Panorama documentary was a failure in leadership, which is why I absolutely welcome what you say about exec and non-exec colleagues undertaking that leadership role and being visible and spotting things for ourselves, because that's what leadership is about. But two further comments. The first is that we need, as an organisation, to be sure that we've got leaders at all levels that are capable of spotting and reacting to the emergence of toxic culture. And we've had those conversations elsewhere. I'm not seeking to rehearse those conversations this morning, just to note the fact that through board development and elsewhere, we're pursuing stuff around, having a trauma-informed culture, having a just culture and all of that. So that focus on the capability of our leaders in the organisation to intervene and to mould the kind of culture that we want the organisation to have. That's work that's going on, and it's important to acknowledge that. Similarly, I think it's important to acknowledge the fact that we need to do some work around just being able to judge intelligently when people are suitable for particular roles in the organisation and when they might not be. Again, that's work that's going on outside of this board setting, but important to reference that, and for the record, as it were, be aware that that's work that's also going on. I'm going to invite other people in now, otherwise I won't get off my soapbox. So Sharon.
Kevin, you've really covered my area, because I thought it was a really good paper, Anita. And the NHS has many systems, many checks and balances that should prevent this serious systematic failure, but they don't. And it's culture that drives behaviours, and it was about that. How do we test culture at board level and service level? How do we make sure that we're not so focused on performance that we are actually diluting good care, and that we give the same weight to information which might imply a cause of concern as we do to the positive things that are happening in the organisation. It's a really difficult one, but it's how we're measuring culture. We can have values as a board, and we can have values as a team, but how does that translate into behaviours?
Thanks, Sharon. Tim.
Yeah, thanks, Kevin. Tim Harry, non-exec. My comments really have been covered around, what more can we as a board do? And I think what you've highlighted, Kevin, is around, it's that leadership role, and we need to do more and more of it. And I think, Anita, you covered my other comment, which was around, this is not a one-off, it's an ongoing challenge that we've got to set ourselves continuously. And in some areas, we should never feel assured. We've always got to be sort of questioning and challenging. My question really was around, I think, an aspect which I'm not sure has quite been covered. So staff and their sort of response to what's happened, potential impacts on motivation of staff, because there's been some very negative aspects around it. And like most things, you only hear about the things that don't go well as opposed to the things that go well. And I just wondered if there was some communication sort of plan and support for staff around taking them through this.
So actually this was an omission on the paper, and for that I apologise. As well as reaching out to the carers of all of our inpatients, we did reach out to all of our staff and say, it's a tough gig, and unfortunately with some of the media coverage of this, it tends to become a reflection of everybody working in the service. So we did reach out to staff in terms of, are you okay? It's very uncomfortable, and I would go further than that, to watch that appalling level of care, and to know, to be fair, that they are people that carry the registrants and care. So, but we have also, and we're incredibly lucky with our Freedom to Speak Up Guardian. Stu Nielsen is incredibly well respected throughout the organisation at all levels, and we much against his better judgment, have got Stu to do a couple of video logs, and so the people that don't know Stu, we've reached out to say, Stu is here, and actually they've been really positive, because staff that have used Stu have kind of then ended up saying to others, he's really great and really supportive. So it's just been a case of making everybody aware of what we have in place. We've really pushed the freedom to speak up stuff throughout October. but as I say, we have reached out to staff because we knew for a lot they were quite affected by it, and that was important to us.
Thanks, Nita. I assumed that you had, so
Yeah.
thank you for that.
No, it's an omission on the paper, but I apologise.
Thanks, Tim, and thank you, Anita, for that clarification. Let me see, who have I got next? Di.
Thanks, Kevin. Thanks, Anita. I just wanted to just ask a little bit more really around visits, just because I think I've been really impressed with the visits that I've been on with exec colleagues, just in terms of the level of candour that our staff have shown. I think they've spoken very openly, and I think that has been very helpful. So they've said what's good, they've said what the challenges are. I'm just mindful that I think most of those visits have been within the sort of normal 9 to 5 period, and I just wonder whether we need to think a bit more creatively about non-execs, particularly going into to talk to staff outside of those hours. So maybe something to think about in terms of going forward, and also then thinking about some of our some of the people who use our services who are cared for outside of our services, and what sort of feedback we might get on visits that other non-execs are doing in those services, with execs or without them, that again we can take some assurance from.
Before you come back on that, Anita, if I may go first, on your first point, Di, Sarah and I have a plan for as it were, out of hours visits. We'll see how that goes, and if that goes well, then it might well be something that we invite other non-execs to be involved in. Anita, sorry.
The point that I was going to make is we had a long discussion at the executive team meeting this week around the purpose and function of the executive and non-executive visits, and making sure, whilst we don't want to create a reporting and a kind of an industry around the visits, but we absolutely do need to make sure that they're doing what our staff need them to do, because they actually value them very, very much, and we need to get those right. But also, you're right, when do we do them? They're very planned, they're very structured, and that's not always how they should be, really. So it is that opportunity to do both. We also had a long conversation, myself and Jenna, around the board stories going forward, and we heard this morning a fantastic one. I think that's important. But we had, and as a board, we've had this discussion through COVID, and as we've moved to Teams, we've tended to hear nice stuff, and we need to challenge ourselves not to just hear the nice stuff. So that's some of the conversation that myself and Jenna have started, ready for the board stories in 2023.
Thanks, Anita. And you're absolutely right. We need to hear the difficult and challenging and not very nice stuff. I completely concur with that. Ian.
Yeah, thanks for the report, Anita. I thought it was very good, and I should preface what I'm saying as well is with saying that I'm a long way from the detail on that. I'm not at the quality committee, etc. So some of this is very, very new. But the point I just wanted to pick up was how do we ensure that those patients that hadn't shared their experiences with us are picked up? I heard you say earlier about activity management only being part of the answer, and I absolutely agree with that. But I suppose to my simple mind, I'm just a bit concerned that people don't become aware of, or we don't become aware of certain people within the system.
The honest answer to that, Ian, is we'll never get everybody, and we'll never get everybody's thoughts. Some people walk out the doors of our service and will often say to us, with the best will in the world, I hope I never see you again. And they mean that very nicely, that that they've gone through a very difficult time, and they really, in a nice way, want to turn their back on mental health services and know that they'll never use us again. But we and that's some of the, what you've just said is some of the challenge I've thrown down to our patient and carer experience leads to say there will always be the ones that want to come and tell us their story, good or bad, but actually we need to offer a range of opportunities for people to tell us what it is like to be on the receiving end of LPFT. And that's the work that we're doing now, to kind of look at a range of ways of getting feedback and just making sure that we've got all that right, really.
Thanks. Can I just come back on that slightly? Just in terms of people that are in the system at the moment, then I assume from what you've said that we are aware of ones that, if you like, don't want to share their experience with us. Because I suppose what I'm concerned about potentially is someone that sort of turns their back, but they're in our system for quite a while, and we don't go back again.
And that's some of, and some don't, and this is anecdote, we don't, this is the reason why I've asked for a level of independence. I wouldn't want people to think that they couldn't comment on the service if they felt it was going to affect the service they were going to get, which is why I've asked Healthwatch and Voiceability and other independents to kind of work with us around gathering that feedback in case there is something we haven't considered, Ian. You know, we won't know it all. So it's about asking people to say, we have a look at what we're doing, and how can we make it better?
Really helpful, thanks.
Thanks, Ian. I'm just catching up with who else wants to contribute. I think I've got Chris Higgins next. Chris.
Yeah, thank you, Kevin. It was just picking up on the point that Tim Harry had raised earlier about staff and the impact on the staff. Is that obviously quite a lot of work going off at the moment, but just within teams, we're just trying to make sure that there's a opportunity for people to talk about what's happened and what that might mean for them on a kind of more regular and informal basis. I think as we've seen these stories, you can't underestimate the impact on staff. It's the reputation of us all when the NHS is under pressure and under criticism. So, and staff feel that and you know they hear it and they feel it when they're talking to friends and family. People are questioning them about how things could happen, and so we're just trying to put, as well as the kind of formal support structures, what can we do on that informal basis within teams to allow a platform to talk.
Thanks, Chris. That's really important. You know, that despicable behaviour may well be isolated, but the, as it were, the fallout of it affects us all, and our staff deserve supporting and helping through that. And it's worth saying too, without kind of over egging the pudding, supporting them through that in a context of them doing a tough job as it is, you know, and I think it's important not to let go of that. I don't see any other questions or comments, Anita, so thank you very much. A really comprehensive paper. I know there's loads of work going on as well. You know, the assurance mechanisms are good, but we know it's, you know, just reporting those assurance mechanisms isn't a done job. So, and I know that everyone's aware of that. But thank you. I think the floor is still yours, isn't it, for the next item, which is the staffing establishment review.
It is, and thank you very much. And I did sow the seed on the board away day about the safe staffing establishment review. This is it is a very different paper to what we've received previously around the safe staffing review. So, and I'm conscious we've got some new non-executive colleagues and indeed new executive colleagues. So historically, we do this twice a year. We do it every year in line with our requirements as a board, but it has always focused on staffing numbers. And those numbers come about as part of a triangulation, a very detailed safe staffing review, which involves a triangulation of the evidence-based tools which are out there, which for us in mental health is the mHost tool, which staff fill in around numbers of patients, acuity of patients, and that goes through a big system, gives us lots of calculation, tells us how many staff we need on each shift, and which goes on to give us our staffing establishment. We then look at that and use clinical judgment to say, well, that's okay, but we think this and we think that, and we put challenge in. It's not just staff saying we need 37 staff on a shift. There is some professional challenge that goes into that, and then we use some outcomes tool and we come up with a number that we believe should be on each shift on each of our inpatient facilities, and then we set our establishments against it. This time we've taken the opportunity to do something different, because what was happening, it appeared, wasn't necessarily just about numbers and numbers of workforce. So we've done a separate piece of work. So we've benchmarked ourselves within LPFT against other providers of mental health services. And one of the key areas is we've discovered that we benchmark low against our registered professionals, not necessarily just nurses, registered professionals and healthcare support workers. So we have a higher percentage of healthcare support workers on our inpatient facilities than registered professionals. And we've done a detailed piece of work to understand how this feels. And that work is ongoing. We're doing it in considerable detail on Charlesworth ward as part of a continuous quality improvement project, but also across our other wards. So we know that we have heard quite often that shifts feel understaffed, and when we've looked at it, the numbers are accurate and the numbers are in line with our establishments, but actually as a lone registered professional, that can feel quite difficult. So the way we've done this time is we have gone through each of the wards as we would previously. This paper contains also a list of all of the work that we're doing to date to increase our registered professionals. And there are a huge amount of work going underway around how we work with the university to increase our nurses, to increase grow our own agenda and what that looks like. So really and truly, the main focus of this paper is around the shift in balance of the percentages of our registered nurses and our healthcare support workers, and to review the patients of 2022. You saw in the director of nurse, the chief executive paper earlier. I've been around in this organisation for some considerable time, and to be fair, the staffing profiles on our inpatient facilities reflect pretty much as they were when I joined 35 years ago. The patients that we are looking after in 2022 have different needs, and we as an organisation have to challenge ourselves to say, have we got the right skill set on our inpatient facilities to deliver the care that our patients need in 2022? And I think that is very much around looking at our skill mix, looking at the range of professions that we have available to each and every patient. So that's the piece of work that I want to do over the course of the next 3 months. It isn't about numbers on a shift, it's about the skills on a shift and making sure that is right. So you will see in this paper that I make reference to converting a large amount of unregistered professionals, so healthcare support workers, and converting a lot of those posts into registered professionals. So I'm talking, so that is just shy of 30 healthcare support workers over our inpatient facilities. I've met with Amy Beaton, who is the new Director of People. The next piece of work leading on from this paper is to work with our clinical services. It's working with our operational leads, it's working with our professional leads to say, okay, what do those roles need to look like, and what skills do we need, what skills do our patients need us to have? And it's a very different way of thinking. So I'm not going to go over the full detail of the paper, but it is a very different safe staffing paper than the board have received previously. But the key focus of it is we will have clear plans for each and every ward. And the reason I've said it will be 3 years is because we want the opportunity for those staff in those healthcare support worker roles to become registered professionals if they wish, and to do the work that we need to do to support our own, grow our own agenda. Some will be recruited new in, but we need to look at the opportunities we afford our own staff, see if we have enough opportunities and if we have to increase those. So I'm happy to take any comments and questions. It is a very different safe staffing paper, but works very closely with operational services, to be fair, finance colleagues as too, who are all supportive of this approach. So I'm happy to take comments and questions on the paper.
Thank you, Anita. I'm going to go first. I'm just going to say that really welcome the approach that you've taken. You know, we've discussed on a number of occasions, you know, as a board and elsewhere, the fact that we need to move away from just numbers to the kind of profile of capability that we need. And so I think the approach that you've taken is, you know, absolutely, if I may say so, absolutely the right one, you know, in reflecting that kind of capability requirement rather than just seeing people as, you know, in a particular kind of silo, as it were. So thank you. Because I think, you know, long term, that's absolutely the approach that we have to have if we're going to have the right kind of balance of workforce and understand, you know, where our capability gaps are. Tim, have you come on the screen because you've got a comment that I've missed?
No, well, I put a question which followed on from your.
Oh, forgive me, didn't see it.
It
scrolled past too quickly. Go on.
Okay. Well, thank you. And I totally agree with what you've just said. I mean, this is really at the core and nub of the way forward in many of the things we sort of been discussing. And I think, again, I welcome the new report because it really builds well on the induction training that you gave us, Anita, around the MOSE tool. And I'm beginning to understand a bit, you know, because we were sort of scratching our heads a bit around it. There's one thing I'm still trying to reconcile in my mind, and I'm sure it is reconcilable. So we're talking about upskilling, and I fully understand that. And I'm trying to reconcile that with when we talk about new ways of working and new roles, where some of those higher skill roles, part of what they do can be taken by other supporting roles, if you see what I mean, and how that all sort of fits together.
Absolutely, and some of it, so as a board as well, we also heard some time ago, we ourselves had a training session on trauma-informed care and what that looks like. So it is very much, so it is some of the higher end kind of skills, you're absolutely right, but it's also making sure that the lower end staff, that's an appalling use of terms, and I do apologise to anybody that's listening into that, but some of the staff that haven't had the level of training that some of our registered professionals have had, to make sure that the training they're getting is accurate, but to be and right and fit for purpose. But also, Tim, I do have to say we've reached out to the university too to say we're not quite sure that the mental health learning disability training that our staff are getting at the moment is skilling them. There is a recognition from the university that they need to do some work too. So we are working closely with the university. Actually, the professional leads are really linked in to look at the nurse training particularly, to say this has become quite generic, and actually more than anything, mental health inpatient services is becoming very specialist. And staff need that specialism, they need that level of training. So we're doing some detailed work with the university at the minute around what the training of those students look like. So they're coming to us equipped for what they're facing really, and what the new patients need. And I think that's the big thing for me for this paper. This isn't about how many numbers we need. This is about what our patients need to be cared for 2022, 23. And it's very different to what it was in the 80s when I joined us. So yeah, so it's a very different focus. But you're right, Tim, we need to look across the board, and the trauma-informed care work will drive a lot of what we deliver going forward.
Yeah, and I think your point is a much broader upskilling, isn't it, you're talking about? So thank you.
Thanks, Tim. And Anita, in a sense, it takes us back to the previous paper, doesn't it? You know, to have the right kind of therapeutic environment and the right sort of culture, we need to give staff the right tools in their tool bags.
Yeah, absolutely.
Di.
Thanks, Kevin. Thanks, Anita. Again, echo all the comments about the positive approach in this paper. Just a couple of things from me, really pleased to hear you talk about how we are talking to the university about training. A plea, I guess, for training that is strengths based, which I think goes right across from healthcare assistants right the way through to some of our higher band staff. So I think some of it is the sort of the underpinning values and principles that people bring into the role that we need to foreground, really. And also I think to reflect, we've talked about it already in this meeting, about the importance of leadership. And again, I don't particularly like the term, but also thinking then about fellowship. And I think there's something in the space here about team training as well as training for individuals. So I guess any of those conversations that we're having with university colleagues, those would be the kind of things that I would like to see reflected. Just on the paper, and I just wondered, now that we've got the paper, how we might reflect this paper with the paper that we considered at audit committee a couple of weeks or so ago that was focusing on the e-rostering, because I think it would be useful to join the two things up. So one of the things we were very keen at audit committee was not to sort of get too hung up with the kind of transactional information that was in the paper around the e-rostering. So I think there's a real opportunity here to finesse that information with the content that we've got before us this morning. So just to kind of flag that, really. Thanks.
Brilliant, thanks, Di. Some really good points, and I think you're absolutely right. I mean, we've been looking at, you know, the benefits of multidisciplinary whole team training. The benefits far outweigh. It's a challenge. It's a challenge at the moment in terms of getting staff released to be able to do that multidisciplinary kind of the whole team, but we need to find a way around that. I throw the challenge down to ourselves. We need to make that happen, and we need to work through, because we've been saying it for quite a long time now. So, you know, I take that challenge myself. It's not something I've thrown down to anybody else in the room. They'll be pleased to hear, but we have to make that happen.
And I'd be really happy to have a conversation with you offline about that. So yeah, really pleased to hear it. Thanks.
Thanks, Di. One last comment from Girish.
Thank you, Tim. Sorry, thank you, Kevin. Dr. Girish Kunigiri, Medical Director. I fully support the paper. It only highlights, you know, how much innovation and thinking beyond the usual box, you know, to meet some of the workforce challenge. I think what we as an organization also needs to ensure that while we are going through this transition process, which may take a couple of years, we need to ensure that we try to provide as much as possible the right skills and staffing numbers on the wards, because this is not only just to keep our patients safe and healthy, but also to ensure that the confidence and well-being of our existing staff is taken seriously, because you know, staffing levels have really put significant stress on our existing staff as well. So you know, it is very important that we do that during our transition period. Thank you so much.
Thank you, Girish. If there aren't any other, I don't think there are any other questions or comments. Thank you. That's a really helpful paper, Anita, and you know, a route map for what I hope is going to be a really constructive way forward. So thank you very much. Let's move on then to item 4.4. So Girish, I've got to pull you back to the camera, please, for the for that item, which is the Learning from Deaths report. Thank you, Girish.
Yeah, thank you. So with regard to this paper regarding learning from deaths, I take the paper as read. As you can see, some of the trends over the last few quarters, there is some marginal reduction in the number of overall deaths. But as an organization, you know, we thoroughly investigate all serious incidents along with deaths. and some of them, based on their criteria, they go through this mortality review as well. Some of the key themes which has emerged over the period of time is not something new. I mean, basically, they are with regard to communication and having partnership, working with our agencies within Lincolnshire, particularly with the all-call services. And we also heard in our first talk from Alison with regard to the clinicians hearing to the carers and the family's views, which seems to be one of the common theme. And there were also some issues with regard to safeguarding, which has been looked into, and the lessons have been learned. I think during this process, I also need to ensure that the staff, who have been investigating or who have been investigated during this process, who had direct or indirect involvement with the patients and the family, have also been supported. In the 2 deaths that occurred with regard to learning and disability services, they have also been thoroughly reviewed. I think myself and Anita had a meeting in the last couple of weeks, and we have called for a review within our organization in terms of how do we ensure that the process, both with regard to SI and mortality surveillance, is robust, and also ensure that how the learning happens within the organization and how do we actually measure the impact of this learning. So probably when I bring back this paper in the next quarter, the board will be provided some details in terms of what our thoughts are and how we are planning to make it more better. Happy for any questions. Thank you.
Thank you, Girish. Questions or comments from colleagues? I don't see any. Girish, thank you very much for a comprehensive report that, as the absence of comment shows, kind of stands on its own 2 feet. So thank you very much for that.
Thank you. I need to say that all the credit needs to the author, not to me. Thank you.
You can bask in the reflected glory, Girish. Let's move on then to item 4.5. Chris Higgins.
Thank you, Chair. So yes, Chris Higgins, Director of Operations at the Trust. So obviously members will have had a chance to read the paper and obviously briefed our board development session previously, the headlines of the case, but the summary of it really is that on the 18th of October, the executive team took a difficult decision on the grounds of safety to temporarily close our male psychiatric intensive care unit from based at the Hearts Home Centre in Lincoln. So currently suspended to admissions, and we're looking to place the remaining patients that are currently being cared for in that unit. It was a 2-stage decision process put forward as a recommendation and proposal by the clinical services that was then supported by the executive team, and today we're asking the board to ratify that decision. The 2-stage decision really was that firstly we recognised that we've had a number of staffing pressures across a number of different services across the organisation, and that's been talked about in previous meetings. However, they're most keenly felt on our inpatient wards, where we've got to maintain minimum safe staffing levels to ensure safe patient care. And the conclusion that we've reached is, despite our best efforts to recruit and retain staff in different ways, we're currently not able to run all of our wards that we've currently got operational. So a decision, first point, was we need to consolidate the number of wards that we're currently delivering to make sure that we can use the staff to best effect. The next decision point really on that chain was about which ward should we close in order to free up staff and what would have the greatest impact. So that was based on 3 points really. One is the least disruption to patients. So we identified that PQ has a maximum occupancy currently of 8, having reduced numbers during COVID from 10 to 8 as the maximum occupancy levels, and currently has 4 patients in it. So compared to other wards, that's a lot less patients that will be affected if we were to close an alternative ward. The second was about least disruption to staff because of vacancy rates on the unit. we knew there was a lower group of staff, or less staff that would be affected, but also linked to that is the experience and capability of that workforce as such that they could work confidently in any other area of the organisation. So based on the fact of least disruption to patients, least disruption to staff, and the most gain we would get in terms of the workforce that would be freed up, we made the decision to support the recommendation to temporarily close the PQ. So that's where we are at the moment, temporarily closed to admission, or close to admissions, and looking to safely support the draining patients into appropriate care settings. We're not rushing that, we're making sure that those patients complete their care journey. The nature of the PQ service is it's short-term admission rather than long-term care, so it would be appropriate to wait for them to complete and move to their appropriate placement as previously identified in their care plan. The next stage for us, if supported today, is that we're going to enter into a period of engagement with staff and patients and other stakeholders to understand the factors that would need to be put in place for us to safely reopen. Or we want to make sure that when we do reopen, it's done in a safe way and it's sustainable. We don't want to be back here in another few months' time having opened too prematurely. So understanding what those conditions are, what good looks like, is really important before we make a decision to reopen again. So I'll stop there. Happy to take any questions.
Thanks, Chris. And this is a particularly pedantic point, but it's an important one, kind of constitutionally. Although the paper says the exec team has taken the decision actually is a decision for the board of directors, not for the executive team. And although the paper says for the board to receive, actually the decision is the board's, so we actively have to take the decision to support what is a proposal here, not a reported decision. It's important to make that distinction, I think, Chris. I don't think it's your intention to suggest that the board just notes this. It is actually there's a positive decision point here.
Absolutely.
So questions or comments on what is proposed? I don't see any, although I can see a couple of people typing furiously, so I'm going to busk for a minute while I see whether or not they're asking a question or not. Di.
I took assurance from this, Kevin and Chris, in terms of the very careful thought that had been put into reaching the proposal. And the only issue that I had, which Chris you're aware of because you and I have spoken about this previously, was that where we might have people who would have normally come into our PQ service going into a service out of area is really just to make sure that we have the checks and balances in place in terms of in terms of the care that they might be receiving elsewhere. So so I was reassured.
Thanks, Di. Sarah.
Thank you. It was just a comment really rather than a question. Thank you, Chris, for bringing the paper around a link between this item and 4.2 around the BBC Panorama documentary, because I know an area of learning for Greater Manchester Mental Health Trust was around board being cited on hotspots, because I think it's the Workforce Summit and also this paper really brings to the fore, for example, some of the sickness and turnover figures for PQ that the board might not have been cited on before. So I think there's something for us as a in terms of our integrated performance reporting, in terms of how we tease out some of those hotspots in a sort of earlier way. So I just wanted to put that forward as a comment and something for us to take forward. Thank you.
Thanks, Sarah. Look, this is by no means an easy decision for us as an organisation to take, and I'm grateful to you, Chris, in particular, for keeping me close to the kind of decision making around all of this. It is, I think, on balance, given the care that you've taken over the proposal and the way that we've mitigated the risks, is the least bad option for us to take. So I'm going to invite board colleagues to agree with the proposal. So I'd be grateful if people could indicate whether or not they're happy to do so in chat, please. Thank you very much. So that's approved, Chris. Thank you. And you know, for the record, thank you. I know how much care and thought and, you know, rigor has gone into getting us to this place. So, you know, thank you for you and your colleagues for getting us there and helping us take a not an easy decision. Let's move on then, Mark, and it's that bit of the meeting that you look forward to most because it's your opportunity to shine. It's the integrated performance report.
Thank you very much, Chair. So, morning everyone. So I'm Mark Platts, I'm the Director of Finance and Information. So I present the integrated performance report for October's activity today. And if it's okay, I'm going to hand over straight over to Chris to go through the operational updates, and then we're going to pass over a number of directors, and I'll do the close at the end if that's okay. So Chris, if you could able to come in, that's great. Thank you.
No problem at all. Thank you, Mark. So I won't go through the operation narrative today. You've got that to read at your leisure. Just the points that I want to draw out were it kind of links to the staffing issue as we work with Amy Beaton and the team and the operational services looking at our different pressure points. And I would say there are hot spots around the organisation. Picked up on the risk register earlier about our early intervention service is a particular hotspot for us at the minute in terms of staffing pressures. And then we have other teams that kind of moves around, I think it would be the best way to put it, in terms of staffing pressures as people come and go from posts. And we've got at the moment Boston CMHT is another example, as is the children and young people services at Boston. It's just a hotspot at the minute that we're focusing on, but that are likely to shift around. At the moment, just the three kind of main highlights I'll draw out. One is the work continues to recruit additional staff into our core CAM service to improve waiting times. And what we're seeing is 3 of the 4 areas of the county we're seeing improvement. That'll be reported through to Sustainability Committee in November in a bit more detail. But where we're struggling most is around Boston, linking back to that workforce. We're not able to recruit at the pace we wanted to, but overall 3 out of the 4 teams are seeing an improvement in that, which is good to see. Early intervention in psychosis, that's a particular difficulty at the minute in terms of recruitment into that service. A number of people just left for new opportunities at the same time, which left us quite short. So we're doing cross-team working to make sure that we've got some resilience into that service while we recruit additional staff, as well as looking at the pathway and can we do things a bit differently to make sure people are seen in a timely way. The other thing I just wanted to highlight was around out-of-area placements. Last time we reported, we had a few people who'd gone out of area inappropriately. We've returned to 0 on that again, which is a great place to be. But obviously, the decision we've just taken around PQ just needs to be considered in that respect. I would consider those to be inappropriate placements if anybody's placed out of area, regardless of technical definition or not. It's not what we want for people, and we were looking to repatriate those people back into Lincolnshire as soon as possible. So just to keep an eye on the fact that that will probably change over the next couple of months, depending on how many people need to go out of area for PQ care. But we monitor that. Well, I monitor that daily. That's monitored the executive team regularly, and there's an out of area reduction group with system partners where we oversee actions and plans to make sure that we reduce that number to 0 wherever possible. So the other thing just to flag was there's been an exception this month around children and young people eating disorder waiting times. The issue we've got there is we've got quite low numbers, as is reported there. So 1 person means we don't miss the target in terms of the percentage compliance. And so, but as you'll see there, for urgent waits, we've been compliant, managed to see everybody in appropriate timeframes since July, and in September and now into October we've seen everybody for routine waits in the appropriate time. So it just takes a while for that to model through. So that's why you've got 2 sets of graphs there, an in-month graph and the nationally reported 12-month rolling average, because obviously the averages don't pull through for a while. So so stop there. Happy to take any questions and pick up as we go.
Thanks, Chris. Then before we move on, then any questions or comments for Chris? Reassured, Chris, by what you say in terms of enhanced monitoring around out of area placements in the light of the decision that we've just taken. So thank you for that. Who's up next? Anita.
Hello, yes, I'm going to take this as read. There's a couple of parts that I just wanted to draw board's attention to. It's bit so that there are obviously several charts there within this, but it is very difficult with our current data system to produce some of the information that really we would like to include in this. And we've been working through, and in line with PSIF as well, now requirements for the new patient safety incident response framework, we are working through to get the most up-to-date incident reporting system for LPFT, and that will help us with the reporting that we include in the integrated performance report going forward. But just a couple of bits really that I just wanted to bring to the attention. I obviously reported last month that we had seen a spike in serious incidents in July. As you will see from this, they have come back to within normal ranges. So, but we are going to monitor that going forward, just to kind of obviously keep our eye on it, see if it's anything about seasonal variation, or if there's something particular that was going on at that time. So we're doing a great deal of work around themes and trends and unpicking those. You'll see that there's a chart there around AWOL, so that's absent without leave patients. If just to give some assurance, that's not necessarily about people that all abscond from our services, but if a patient goes on leave who's detained under the Mental Health Act and had Section 17 leave form, so if they're given permission to go on leave, if they then don't return at the time that we need them to return, that they're classed as being absent without leave. And if they're detained under the Mental Health Act, that is STICE reportable. So it's not necessarily people that are leaving out of our units without, it's people that haven't come back from leave. But we are doing a really detailed breakdown of that work and doing some themes and trends. There is a brief update there, giving you an update around the patient safety incident response framework. We are pushing forward with that. We are doing incredibly well, reaching out to some of the pilot sites. So there's lots of work going on around implementing patient safety. Complaints, that work is there. And Girish and I, so the new medical director and myself, we have met again with the complaints team this week to make sure that all processes for both medical staff and all of the staff in the organisation are aligned. So we're doing some really good work around that. So I'll continue to keep board and quality committee abreast of the work that we're doing around complaints response. The one piece in this that I just wanted to bring to your attention is the patient and carer experience of being on a waiting list. I know it's a conversation we've had many times as a board. It feels very uncomfortable to have waiting lists. It's something that, you know, it is new to us really, mental health, over the last couple of years as a result of kind of the huge demand of our services. But I'd like to thank Children and Young People Services that have worked really hard, and the patient experience team. So we're doing a piece of work around how it feels to be on our waiting list, and we're not doing that while people are on the waiting list, because the chances are likely they're going to say to us, I'm not happy to be on the waiting list. Of course they're not. We accept that. But what we're doing is, as people come into the service, to ask if they felt that there was more that we could do. So that is an excellent piece of work that's happening, and the findings from that I plan to feed through into quality committee so that we can monitor that. So I think that's a really critical piece of work. We know we've discussed that several times. How does it feel to be kind of on a waiting list, and have we got that right? So I'll make sure that that information is fed through. There are some charts there and some information around self-injurious behaviour. We know it is a key theme, particularly on a couple of our wards at the moment. I have asked several people that are involved in this to really put a detailed quality improvement programme around this together, including our trauma-informed care and all the work that I spoke about earlier. It's important that we can demonstrate that the work that we're doing is giving an improvement to the service users that are in those areas. So there's a really detailed piece of work going on around there. So I'm happy to take any questions on that part before I move on to the safe staffing section, which is is a summary of the safe staffing. But I'm happy, I can see that Chris Wright has potentially got a question, so I'm happy to take that.
Yeah, thanks Anita. Chris.
Sorry, I can't get my camera on. Thanks, Kevin. Thanks, Anita. So it's going back to the top of your comments around the reporting system, and is there functionality in Datix to provide us with what you'd like us to see, or do we need, and are we looking to procure an entirely new system for that?
So the honest answer is the new, most up-to-date Datix system certainly does have the functionality that we're talking about. We don't have that. Our system is quite old now. There have been several versions compared to the one that we have. I know Jenna Davis, our Director of Corporate Governance, has worked with a far more up-to-date version that does give us the functionality that we need it to give us. So that's what we're looking at. We are looking at others. So the procurement process and kind of we're rolling that ball now and kind of looking at what else is available. But having spoken to other providers and other health organisations, the most up-to-date Datix system does give us the functionality that we'd be looking for.
Okay, and so do we have a kind of timeline around when we'd be likely to procure and implement such an upgrade?
I will answer that at the next board meeting. I'm not going to give you a timeline today. There's lots of conversations going on over the course of the last 2 weeks, so we're really pulling that forward. So certainly next time we're together, I'll give you an update on that one.
Thanks very much.
Thanks, Chris. So Anita, back to you.
Yeah, just in terms of the safe staffing numbers, I am working on how I present the safe staffing as part of this IPR, but we know we have got staffing issues. So in terms of this report, it does talk about, and I think one of the key issues, and actually I'm certain Amy Beaton, the Director of People, will pick this up, and we have had these conversations. We are having more and more healthcare support worker shifts that go unfilled, and that's something that we're really working on. And actually that the paper that I presented earlier and some of that transition will help some of that work so that we make sure we've got the right skills. What this report in its current format, and I do have to talk about some of what isn't so good about it, what it doesn't necessarily always cover. So when it talks about shifts being remained unfilled, so that it sometimes doesn't account for the moves that happen that evening. So as a board, we heard from our out of hours coordinator some time ago that spoke about some of the chess pieces they have to do sometimes. So if we have a ward that we haven't managed to fill some of the shifts, we'll move other staff about, and sometimes that doesn't get reflected onto the rosters. And I know some of the roster work that is being led now will pick some of that up. So it does talk about the shifts that remain unfilled. It talks about us having a high percentage of fill rates on nights of some of the wards. So just so people know that the percentage fill rate is against the establishment, and on a whole most night shifts have establishment that is lower than the day shift because there aren't ward rounds going on, there aren't trips to other appointments, etc. So if we're putting lots of additional staff on night, if we have patients have additional needs, it will send that percentage higher. But I am working on how we present this safe staffing paper to us for exactly the reasons that Chris Higgins spoke about in his previous paper, and the hotspots. Are we able to look at this and say, actually, that's a real hotspot in terms of those they have remained unfilled shifts. That's potentially, you know, something we want to go and dig in deeper. So it is work in progress, and I'm happy to take any further questions.
Thanks, Anita. I was going to make this observation later, but I'll make it now because it fits with the point that you've just made. I know that Jenna, our Director of Corporate Governance, is leading a bit of work to look at how we present our performance information, and particularly how we triangulate stuff. So to use technical terms, so we need to see this report as something that's going to be refined and which is going to focus more on that kind of triangulation and links. So, you know, your point is A, both a good one, and B, something that I know we're working on behind the scenes. So thank you, Anita. I think then we'll move on, shall we, to the people element of the report. Amy, welcome.
Thank you, Amy Beaton, Director of People, and delighted to be around this table. So if I just pull out the main parts of the people section on the report, from the exec analysis section, actually, I'd just like to highlight some of the conversations that have already been had in board today around our improvement journey around workforce data. We've done a lot of work over the last year to improve that. And that continues, and I think a lot of progress has been made in divisions having better data insight. However, as the point was made by Sarah, we're still working with BI colleagues in how we present the data into exec team and into board, in order that we slice the data in a way that we are able to see hotspots, and Sarah referred to the PQ as an example of that. So work is currently occurring there around our workforce data. In terms of sickness, in the report, as was said in the chief exec update, we are dealing with a number of outbreaks, and therefore you would expect that we are seeing a resulting impact on our COVID sickness and isolation. It is still a top reason for sickness within our trust, infectious diseases. And therefore, because at the minute we're not operating that command and control structure with the incident command cell, we have increased our tracking of sickness within the function. And that's not just limited to actually COVID, that is beyond, because as you'll see from the Workforce Summit, there is an action around HR business partners really having a robust plan for sickness within their divisions, as stress, anxiety and depression is another top reason for us within this trust. And as colleagues have already mentioned, high turnover, high vacancy tends to then show high sickness. And the PQ paper also has shown there was a disproportionately high sickness rate in that area, and that has impacted on our figures. In terms of turnover, as Anita had just alluded to, what I wanted to pull out, highlight to the board, is the turnover rate in our additional clinical services group, which is our support staff at that bands 2 to 4. This historically has not been a staff group we've struggled to recruit to, and now we are. So not only are we seeing it with quite clearly the highest turnover rate, it is also our second highest staff group in terms of vacancies, and we're really struggling in that staff group at the moment. And reference was already made earlier around what we're doing in terms of cost of living, because we're hearing that our walking in your shoes showed that pay is a main reason why people consider leaving us, and that is translating for this staff group. The paper refers to some more of the actions that we're taking, but as Anita said in the establishment review, that is also where the strategy of changing the ratio around registered professional to healthcare support worker would certainly help with this picture, because although nursing does account for most of our vacancies in the organisation, our turnover rate for nursing is actually not as problematic as for this staff group, and is actually quite positive when compared to national. So in terms of vacancy rate, I just wanted to highlight to board, whilst we do see an increase in vacancy rate, I think that this is largely, we can demonstrate it's largely driven by our increase in establishment, so our continuous growth. So I would want to provide assurance that We are increasing our actual numbers, but it just does not happen as quick as our growth. And that is across all of our staff groups. But having said that, what I would want to highlight is nursing is definitely an area where we've seen the slowest increase in actual numbers. And therefore, that's why the paper focuses on what we're doing around international recruitment and maximising our apprenticeship levy with our registered professionals in order to support that. And we saw those numbers presented in a previous paper. And finally, I just want to highlight in the report, it refers to the plan for every vacancy work. And this is a really great piece of work that's been driven by the HRBPs within the divisions. And we're working with operational colleagues around this so that we focus recruitment in the areas where it matters most. So we're working with ops colleagues around, you'll not be surprised, obviously, early intervention, CAMS crisis enhanced treatment team. These are forming on the top more of the priority list where we see an impact on patient experience. And discussions also around that if we do have limited supply, particularly, for example, in nursing, where in our services do we need to be prioritising those nurses to be, and where could we also look for other registered professionals? And this builds on the conversation that's already taken place today around we are looking at non-traditional workforce models and ways of working now in order to help bridge some of that gap. And just finally, actually, to pull on, we have heard today around the importance of leadership, and as a function, we've done some triangulation across sickness, turnover, vacancy, and we've liaised with Chris Higgins, Director of Ops, around where we would have the most impact with our organisational development team supporting. And so at present we have got interventions with our Band 7 leaders in our adult, inpatient and urgent care division to really work with them, as that is the division where we're seeing the metrics across here showing hotspots. Thank you.
Thanks, Amy. Tim.
So Tim Harry, Non-Exec Director. Amy, thanks for that, and really good to hear about gaining more insights from the data. So for instance, around the split between growth and sort of baseline, and I'm sure that will continue to come this way. I've got a very specific question around international recruitment, and I'm not sure you'll be able to answer it, but I'll ask it. So we're increasing the numbers that we anticipate that we're going to be able to recruit from international recruitment, and I assume that's a pattern across many other trusts, but there has to be a finite pool of international nurses. I mean, let alone the sort of ethical question, how many should we recruit? But I just wondered, how do we get a sort of sense of what that pool actually is?
It's different for mental health nurses, obviously, rather than general nurses. And we have built a very strong relationship already in the Caribbean with those international nurses that we've recruited. And we've also actually now looked to do a combined recruitment in India with other provider colleagues, and also with the ICS in Yorks and Humber, of which they have a relationship with the Indian government where they're feeling that the numbers that we need across the two ICSs are not posing an issue for them. And the relationship that they have built with the Indian government is one which takes account of that ethical question that you've just raised in terms of giving back. So There is talk about those that we recruit returning to their home country and during working for us to give back and the learning, you know, looking at our management colleagues going. So there's a memorandum of understanding being drawn up in that situation where, one, they don't think that the numbers we want will pose a problem, but two, also there's a real strong building of a relationship. And there's a number of agencies that have been exploiting, I think, in countries. And actually, the memorandum of understanding between us is one that talks to that issue and gets around us helping that not to occur for the doctors and nurses within their own country. So they're really happy to form that relationship with us.
Thanks, Amy.
Thanks, Tim. Amy, one very small question from me, and that is that the splitting out of vacancies around new services and existing services, you allude to the fact that that needs doing, and obviously it does, to give us you know, better insight into where we're actually carrying the vacancies. What's the timing on being able to disentangle that and report it separately? Okay.
We've done it, it's completed. So we have now separated the vacancies into core and new, and that can be split down right into a service level.
But not in this report though.
No.
So my question is, when will we see it in this report?
You can have it for the next board. We can see that for the next board.
Yeah, because without that, we don't have a proper picture, do we, on where we're really carrying vacancies, as it were. You know, they're all real vacancies, but you get what you know what I mean.
Yeah, absolutely. I can do that for the next board.
Thanks, Amy. I don't see any other questions for you, Amy. So, Mark, it's back to you.
Excellent, thank you very much, Chair. So good morning again, Mark Platts, Director of Finance and Information, and I'm going to draw the presentation of this report to a close, really. And I think some really important discussions that have just gone through in those first couple of sections, and they all materialise themselves into a financial position that more than reflects that. So in terms of our operating surplus and year to date, we are, as you'd expect with the level of vacancies that we've been talking about and the challenges around recruitment, we are reporting a favourable position to our financial plan, because those level of vacancies, we're not spending the cash that we thought we would do on staffing resources. We do still currently forecast a position where we'll be meeting our financial plan. However, national guidance is due to be released shortly, where we'll be expected to be allowed to re-profile our forecast and update it to reflect our true kind of position where we are as an organisation and as a healthcare system. So from our month 9 report, so we'll be seeing it in the January report that we come to board in January with, we are being given the opportunity to reflect a revised forecast, where I do anticipate the level of vacancies that we do still have in the organisation may materialise themselves into a greater surplus than we'd possibly planned. So just wanted to make that reference there. There is a bit more of detailed paper being sent to the private board for board members to give a bit of context around that one. As we talked about the PQ and the challenges around agency usage across the organisation, that has really come to light in terms of our expenditure. So it was only a couple of months ago, back in July, where I was saying we're strategically managing the use of our agency. We'd really made some good inroads around medical support, and we were focusing on supporting our improving access to psychological therapy services around agency. What we are seeing this month is actually we are seeing a significant growth of agency across all categories, apart from the corporate and admin category. So there's a clear parallel between what we've been talking about the rest of this morning and what's happening in terms of our expenditure and our reliance on that agency. And as we did say, you know, come the increased use of agency comes that real big concern around how do we maintain quality and how do we make sure that we're giving our patients the best quality service that we can, hence the PQ discussion. So that's an area that we do need to watch. That is entirely consistent across not only us as Lincolnshire healthcare system, but I do know across the region, and it's something that's being looked at nationally, because the spend on agency is driven by 2 key areas really. One, the desire for it and the need for it, and one, the cost of it. And what we are starting to see now is agencies are kind of upbidding the rates that we pay for staff really across the region. So that's been looked at nationally and is being pulled through as part of a national response. My final update from the financial position is around the capital expenditure. So it does appear on the face of the numbers that we've got a significant year-to-date underspend. I'm entirely comfortable with that, and we'll be saying to the board that we will be spending that as we continue the work on our Ellison Castle acute inpatient wards that are on the Lincoln County Hospital site. That slight delay is a result of COVID and delays in getting materials in, but we're very clear we will be receiving handover of that building in January 2023. So we will have caught that up by the end of the year. So that's the end of the update for the finance section. Just before we go into questions, Kevin, if that's okay, I was just going to draw on your comment at the start about we are looking to refresh this report. And myself, Amy, Chris and Jenna have all met as an exec team to see how we can do that and how we can move it forward, refining it. The areas we talked about, the core and the non-core vacancies, that's an area that we'll be reporting into next month along with other areas as well. So hopefully we'll start to refine it and give that more triangulated position, but happy to take any questions if there are any.
Thanks, Mark. I've got Chris Wright first.
Thank you, Kevin. Chris Wright, Non-Exec Director. Thanks, Mark, very much for a comprehensive overview. I wonder if you could just give us a bit of an update on the capital programme and any information you might have around the out of budget discussions around Boston.
Yeah, thank you very much, Chris. So we've had some positive discussions with NHS England and the Department of Health and Social Care around funding the Boston scheme that we have. So we have now had our outline business case approved. So we're now working with our construction partner to finalise those costs and get that final approval so we can start work on site. As part of the approval, we have been given permission to proceed with working on that now. So there is a bit of movement on site, and we are getting developers back in to bring the site back onto life. We've had a really good couple of engagement sessions with the public over in Boston over the last couple of weeks, and thanks, Chair, for dropping in and being part of that. So that's allowed us to really give a good perception of what we're doing with the scheme to the public, so we can help understand the development and move it forward. So things are looking positive on that front, Chris, and I'll be giving a bit more of a detailed update at the Council of Governors next week, and we'll be getting hopefully final business case approval in the new year.
Great. And Mark, could you just say something about where we are in the existing programme as well, in relation to the ward at Lincoln? Yeah, so the ward at Lincoln, we are seeing, as we're coming to the closing stages, that we are seeing some increased costs around that scheme. So a lot of it is around the pressures that we're all feeling personally around the market and the costs of things within the market. What we are now proactively doing, not only as a trust, but also as a system, we're actively managing the rest of our capital programme to mitigate that, because we do have a capped allowance in terms of what we can spend as Lincolnshire on capital this year. So we are working with our acute and community providers to make sure that we're pausing schemes or not necessarily starting to commence those schemes that were a low priority but planned for this year, and we'll make sure we can pick them up in future years if they are required. So at the minute, although the Lincoln scheme is looking to overspend, we will be managing that within our current capital envelope with the control of other schemes that we've got in place. Thanks very much.
Thanks, Chris. Tim.
Hi, thanks, Mark. Can we just go back to agency staff, because you made quite a bit in that, and it's a question coming from a point of ignorance. So the rates that we actually pay for agency staff, are they locally negotiated or a mix of local negotiation and national determined? And
so there are national caps, Tim. So we do have to report compliance against those rates that we do pay for agencies. So there are a number of approved frameworks out there, and they're kind of nationally capped in terms of that expenditure. What I would say is, as with any demand and supply market, there are challenges to remain compliant with that. in terms of that rate cap.
And it is that demand piece, isn't it? And I guess the second is a comment, and not for answering now, but it's sort of interesting in that there's always going to be a requirement for some level of agency staff, I would think, simply because of, you know, various sort of circumstances. But there's probably an optimal level of interdependency rather than dependency and overusage of agency staff. But I just wondered if we knew from a financial modelling what would be the sort of level of agency staff that we would ideally say allow for in our budgets.
Yeah, what we'll say on that one, Tim, just a really quick reflection. Although we're overspending on our plan this year was lower than we've had for previous years. So I think from that perspective, although it looks like it is an overspend, and obviously it's something we need to proactively manage, but we are still spending less than we would have routinely even pre-COVID. So I think that in terms of context, it's kind of against a planned position, not great. Overall, we are broadly consistent with how we've been operating over recent years.
Yeah. Okay. Thanks, Mark.
Thanks, Tim. Di.
Thanks, Mark. A really helpful conversation, and I'm really pleased to hear about the kind of bringing together of different sources of data. It just made me think in terms of the whole sort of IPR that we've done, in terms of the areas that we've talked about our flows through services. We've talked quite a lot about waiting times, and you know, we seem to be well sighted on that. I guess I'm just left wondering, thinking about the agency staff position, thinking about our earlier discussions about staffing levels, just where we are in terms of average length of stay of our patients, and whether we're starting to see any impact there in terms of how long people stay with us, and what the financial impact of that is, and also of course what the sort of quality of care impact of that is. So I guess just going forward, I think I'd just like to understand a bit more about how some of these factors into play, particularly in terms of the people who are not just waiting for our services, but once they're in a service with us, how long they stay with us, and whether that's being prolonged as a consequence.
Yeah, great thought on that, Di. We're definitely going to pick that up as we move forward, refining the integrated performance report.
Thanks, Di. No more questions. So there's been a request in chat that we pick up a discussion around agency staff in private board later on today. So we'll do that. Make sure, colleagues, if you would, to nudge me if I don't manage to find an appropriate home on the agenda for that conversation. Thank you, Mark, for walking us through the topping and tailing the IPR, and thank you too to colleagues that have helped us through that. My plan is now to just have a quick burst for the finish line rather than take another break, because we've only got a handful of agenda items to get through. Hope that people take the hint that we might do it with a degree of alacrity, as it were. So next item is report from the Audit Committee in October. Ian.
Yeah, thanks, Chair. Ian, our Audit Chair. I've got my spikes on. In terms of the report, the first of the two reports I've got, I should say, this one is a regular highlights exception report from the meeting of 6th of October. It was my first meeting, so I would in particular like to thank Mark, Jenna, Karen and their support staff for their work in producing the papers for this report. In terms of issues we covered, it was a fairly busy agenda. I think we covered a couple of internal audit reports, roster management and cyber security, where we've got partial assurance and clearly have plans to make sure that we follow through appropriately on any of the recommendations there. As well as that, we received positive assurances in quite a number of areas, really. We undertook the annual review of the Audit Committee's work, which comes in the follow-up paper. We also heard, in terms of the Freedom to Speak Up report, positive sort of issues were raised there. Similarly, from the local counter-fraud specialist, we had at our meeting for the first time the new external auditors, so they were able to outline to us some of their initial planning arrangements for 22-23. In terms of decisions, we agreed at the meeting that the annual report in terms of reference were appropriate. We also agreed retrospectively that a piece of work that Mark had led on in the 2021-22 national cost collection exercise was approved and adequate for what was necessary for Mark's submission to the NHS, and we also approved the BAF for this meeting. Just to summarise quickly, from my perspective, I'm assured that what the audit committee has been doing was effectively discharging its duties. So really, the recommendation is if there are any comments that the board wants to make, then I'll try and answer as best I can.
Thank you, Ian. Questions or comments on the last? Where am I? I'm losing track of where I am now. Yeah, questions or comments? We're on the audit committee, aren't we? Questions or comments on 7.1? I'm only looking slightly confused because I don't actually have a copy of 7.1 in front of me, but I don't see any, Ian. So should we move on to the annual report of the audit committee?
Yeah, I will. In terms of the annual report, key aim of this was obviously it's an annual report to provide assurance to the board that the committee met its terms of reference for 21-22. So it's a backward look, and the report effectively summarised a range of issues that you'd have expected the audit committee to have been involved in throughout the year. Just to all this is contained in the report, but just to give you a sense of how the compliance was reached. Clearly, the overall issues of the governance of the trust and ensuring that the committee is scrutinising risks and controls was clearly occurring throughout the year, and that was consistent with the guidance provided from the wider NHS. The panel, or I should say the committee itself, had appropriate membership of non-exec directors and of course all of the exec corporate leads, so Director of Finance, Director of Governance, etc, etc. The committee covered off all the key internal controls and governance arrangements, and I think important to add that it didn't receive any significant breaches of governance over that period. It received a number of internal audit reports, as you would expect, with various assurance levels offered, generally favourable, and the head of the internal audit provided his opinion, which formed part of the Trust's annual governance statement. The panel also heard from the Freedom to Speak Up Guardian regularly throughout the year that provided good independent source of assurance. And I also was closely hearing from the external auditor throughout the process, which in 21-22 was Deloitte's. Final issue probably to mention is, of course, the committee heard and received all the information relating to the annual accounts, and a particular nod to ensure that the trust was a going concern in future. So in terms of looking at that, all of that information in its rounds, it's clear that the committee fulfilled its terms of reference, and I think it's fair to say it can provide the board with assurance that it scrutinised, that it did scrutinise the controls and applied any additional measures to enable the trust to be compliant with its statutory duties. I think the board is as a final point, the board is asked to determine that it has assurance that the audit committee did meet its terms of reference, and then I think our internal process is for a report now to be provided to the Council of Governors. Thank you.
Thanks, Ian. Any questions or comments on the Audit Committee annual report? It's comprehensive, helpful. Thank you very much. Thanks, Ian.
Yep.
Let's move on then to final two items, Jenna, which are with you. The board assurance framework first.
Yeah, thanks, Kevin. So I won't, I'll take the paper as read because they've been reviewed by each of the committees and they were reviewed in its entirety by Audit Committee. So I'll just take questions.
Marvellous. Any questions for Jenna? I don't see any, so we note that. Thank you very much. Jenna, and the last item is the forthcoming board programme.
Which is information, so I won't add anything further on that.
Yeah. Noted. Thank you. I don't have any other business and I haven't been notified of any other business from anyone else. So I will draw things to a conclusion. Thank you very much, everybody, for contributing this morning. I think it's been, again, a really positive meeting. We've tackled some fairly weighty issues and I'm grateful to people for the diligence with which we've done that. So let's carry on in that vein in the private meeting. It is now 5 to 12. If people are content, I would propose that we reconvene in private at 12:30. Are folk happy with that? Shout or wave your hands or something if you're not. Grand.
Perfect.
Okay. See you again at 12:30. Thanks very much, everybody.
Thank you.